I'm Dr. Naomi Cruikshank, and I'm currently a core surgical trainee within the East Sussex Healthcare Trust. Today I'm going to speak to you about how weekly simulated patient scenario teaching helped increase the confidence and preparedness felt by final year medical students for their final year exams and for starting work as a junior doctor. Last year, I was working at the Royal Bournemouth and Christchurch hospitals as a trust grade doctor after doing my foundation years there. During this time, I ran weekly simulation sessions for the final year medical students who are based at the Royal Bournemouth Hospital. Teaching covered common medical and surgical emergencies linked to their curriculum. On average, 3 scenarios were run per weekly session, and these ran over a 6-month period. Each sim session was run in the simulation lab with the aid of a sim man. The students were given an introduction to each session and a short brief before the simulation was run. Each simulation was focused on one emergency at a time, such as septic shock, and the simulation man was programmed to reflect this. Vital observations such as heart rate and blood pressure were programmed and could be adjusted depending on the student's management plan. For example, the sim man would respond and either improve or deteriorate. Other skills the medical students were routinely asked to perform included taking a focus history if appropriate, examination in the format of an A to E assessment, and analysis of various investigations such as blood tests, radiology results, arterial blood gases, and ECGs were all frequently included for analysis. The skill of handing over patients to other colleagues and escalating concerns were frequently simulated also, with practice at handing over in a clear, succinct manner using SBAR as a model. Frequently, students reported anxiousness and lack of confidence for their upcoming exams and for the beginning of their careers as doctors. To evaluate the usefulness and preparation that regular teaching provided, the medical students were asked how confident and prepared they felt at different stages of their training and after starting work as junior doctors. As part of the teaching for the final year medical students, a regional mock OSCE was held. 2 OSCE sessions were run, one in the morning and one in the afternoon. In total, 21 medical students participated in the day. The OSCE was in line with the University of Southampton's OSCE circuit and included stations on history taking, examination skills, clinical skills such as suturing, communication stations such as breaking bad news, radiology, prescribing, and emergencies in the form of managing an acutely unwell patient using the sim man. During the introduction for the regional mock OSCE, the final year medical students were each handed a questionnaire to complete. 2 questions were asked. The first being, how confident do you feel for the upcoming actual OSCE? With 1 not feeling very confident at all and 10 feeling extremely confident. The second question was, how well prepared do you feel for the actual OSCE? With again the same ranking score. This time 1 not feeling prepared at all and 10 feeling extremely well prepared. The students circled a number from 1 to 10 and the questionnaire sheets were collected anonymously. After completing the OSCE circuit, the students were asked to provide feedback on their session. Part of this feedback was collecting scores on how confident and how prepared they felt for the real OSCE. The average pre-mock OSCE level of confidence was 5 out of 10, and this improved to 7 out of 10 post-mock OSCE. The average pre-mock OSCE level of preparedness was 3 out of 10, and this improved to 6 out of 10 post-mock OSCE. Medical students then sat their OSCE as part of their finals exams. After this, the students were then sent a questionnaire online asking them how well the sim teaching, skills teaching, and regional mock OSCE gave them confidence for their real OSCE as part of their finals exam. They were also asked how the teaching had prepared them for the real OSCE. On average, the medical students felt that the teaching had given them a 9 out of 10 level of confidence for the real OSCE, and on average the medical students felt that the teaching had given them a 9 out of 10 level of preparedness for the real OSCE. A couple of months after starting work as junior doctors, the same group asked how well they thought the teaching gave them confidence and preparedness for being a foundation doctor. The average level of confidence and preparedness from the teaching were both 8 out of 10. Weekly teaching for the medical students was focused around managing unwell patients and giving the medical students a structure of how to approach this that could be used for any patient in any speciality, and whether the patient was known to them or as an on-call emergency. Transferable skills such as how to hand over patients or escalate unwell patients was also covered on a regular basis. In summary, regular simulated patient scenario teaching, skills teaching and mock OSCE preparation sessions gave the final year medical students increased confidence and preparation for their final OSCE exams, as well as for being newly qualified junior doctors. Thank you very much for listening. This is the end, and I'll take any questions.
Good morning, everyone. My name is Josef Trapani, and I'm presenting on behalf of my colleagues Michelle Camilleri and Maria Cassar from the Department of Nursing at the University of Malta. And over these few minutes, we'd like to share our experiences of designing and delivering this online program, the BSc Honours in Health Science, that is run by our department at the University of Malta. So as a bit of background, this is actually an academic top-up program. So it's intended to help practitioners update their diploma or their traditional qualification, what we call a traditional qualification, to a bachelor's level. And the reason for this is that in Malta, and also possibly in most other countries, but in Malta there are various health professionals where members of that health profession might have joined that profession through different qualifications. So for example, let's take nursing for example. You could have people with the same professional qualification, that of a registered nurse, but with different academic qualifications, for example, with a diploma, with a higher diploma, with a traditional qualification dating back from before these courses moved to university status. So apart from helping these health practitioners to improve their qualification to a bachelor's level and therefore to improve their career progression and possibly further their studies later, this program obviously helps to and tends to help health professionals to develop critical thinking skills, critical reading and writing skills, and most importantly, to question their own practice. We believe this is very important because beyond the degree itself, we want practitioners to become more reflective and therefore more effective practitioners. And this is of course based on research that has consistently shown that health entities with a higher proportion of health professionals with higher academic qualifications are associated with improved patient outcomes. So the course is delivered fully online. Mainly it is delivered asynchronously, but there is also a strong synchronous element as well. It's a flexible program. It can be completed in as little as 1.5 years to as much as 4 years. And this depends on how intensely students want to study, basically. And they can even change the speed of the course along the course itself. And to complete the program, students need to complete between 60 and 90 CTS, and this depends on their previous qualification. And the students need to do 3 core compulsory modules and a number of elective modules. So we have 3 compulsory modules that need to be completed by all participants in this order: evidence-based practice, research methods, and dissertation. And then, as you can see, there's a range of elective modules, all online, all fully online, and students have to choose a number of these in order to graduate. So over the next few minutes, I shall be using the SWOT model to discuss what we feel are some strengths, some weaknesses, some opportunities, and some threats to our program. Probably the most significant strength is that this was the first, or one of the very first, fully online programs delivered at the University of Malta. And this has given the opportunity to literally hundreds of clinicians to further their studies in a course that would otherwise have been literally not possible at all. And here, full-time clinicians with young families come to mind, clinicians with several other commitments. And we've heard this time and time again, had this course not been delivered online, it would literally have been impossible to get released from work, to attend lectures, to leave family members behind in order to attend, not to mention traveling and parking difficulties. But apart from that, the course has a very strong interprofessional education element, which I think ties very well with the sub-theme of today's conference. And this is twofold. First of all, the course is designed and delivered by a multidisciplinary team of very committed lecturers from a range of academic and clinical backgrounds, but also the students themselves, the learners themselves, come from various health professionals, nursing, occupational therapy, physiotherapy, environmental health. We've had students from medical lab science and students even from dental hygiene, dental technology. So it's an interdisciplinary program, which we feel is a strong, an important strength. And there are various multiple communication channels through which students can interact with each other, with the lecturers, with the coordinator of the program. Another thing which we feel is an important strength is that along the years, and also by learning and reflecting through our own successes and weaknesses, we developed a number of transparent and organized operating procedures. For example, we set a number of minimum standards that need to be achieved for each module. We have developed our own etiquette guidelines, and we have created standardized rubrics for similar modes of assessment along the program. So just to give you an example, this is the etiquette guideline that we developed, and this is displayed prominently both in text form and as an infographic on the virtual learning environment. And this is an example, just one example of the rubrics we developed. In this case, this is a rubric to guide the assessment of online discussions. And here the aim is, first of all, to achieve some sort of standardization across the different modules, but also to be totally transparent to the students so that they are well aware in advance about the basis on which their work is being assessed. Another important strength is that we strive to achieve alignment between intended learning outcomes, teaching activities, and modes of assessment. And we do this, obviously this is an important feature of all types of programs, but we feel this is even more important in online programs because the clarity of expectations and especially their rationale otherwise might not be so clear. Feedback is a cornerstone of our program, not only detailed and timely feedback, but also feed-forward. So feedback is both formative and summative. We strongly believe in instructional scaffolding, and the feedback to one study unit can easily feed on to another module and eventually the dissertation, and also within one module. So feedback on one discussion may pull in to a subsequent activity, and we feel this is very important, of course. But perhaps the element we are most proud of is that we strive to achieve a community of learners. So we strongly believe in the concept of communities of practice developed by Leib and Wegener in the early 1990s, and we strongly believe that as academics we are also learners, and that students can also be educators, and that basically at some point in the program everyone has learned something. These are in fact some of the strategies we use to develop an online community of learners. Obviously we can't go through them all in the limited time we have, but for example we strongly believe that students should be encouraged to help each other even in an online environment, and when they ask questions initially we try to refrain to encourage other students to help each other rather than ourselves. But also simple things such as icebreakers, etc. have been found very helpful to build an online community of learners. And earlier on, I spoke about the congruence, the alignment between intended outcomes, activities, and assessment, and also the clarity of what is expected and Why? And one thing we try to achieve this is through the development of a course map, what we call a roadmap for each study unit. And here students can read exactly what sort of is going on in each, not just at program level or at module level, but even in different phases of each module. So students know what are the intended outcomes and why these activities have been designed, or this assessment form has been designed directly to address that intended outcome. Moving on to some weaknesses of the program. So we are conscious that perhaps given the range of health professionals we try to target, perhaps our elective modules do not adequately cover all the disciplines. However, we try to use flexibility to turn this weakness into an advantage by presenting these modules as an interesting learning opportunity about topics with which students might not have been familiar. We do acknowledge some discrepancies between modules, both in terms of commitment and possibly in terms of quality. Also, although this is a fully online program, when it was developed, it had to adapt itself to structures and procedures of our university that are mainly intended for courses that are delivered face-to-face or for modules that are delivered face-to-face. And this could vary from assessment regulations to recognition of academic effort, even remuneration of visiting staff, even simple things such as formal module evaluation, for example. Students might be asked to indicate whether the lecturer's attendance was regular, whether the lecturer was punctual, which doesn't make much sense in a module that is delivered mainly online and in an asynchronous fashion. And also, although this study unit is fully online, so far most of our participants have been based locally in Malta. So it seems that we are still not entirely tapping the greatest advantage of online learning, that it should not be restricted by geographical location of its participants. And despite being an interprofessional program, so far most of our students have been nurses, but other health professions have been represented as well, but in much smaller numbers. But again, this perhaps represents the actual landscape of the health profession. And perhaps the most important weakness is our limited human resources. For example, as a module coordinator, I have to design the program, I have to deliver the program, I have to assess the study unit, I have to troubleshoot most technical queries, which usually works, but obviously ideally this should be addressed by a team of people rather than an individual. These are some opportunities looking forward. Some are self-explanatory. We do intend to reach out to more clinicians in different settings and disciplines. We also are doing an effort to reach out to students based in different countries now. So this is mainly being done by online marketing, but also through virtual student mobility. The Erasmus program is actively exploring virtual mobilities now, even more so in the context of the pandemic we're living through, and our program is ideally situated since it's delivered entirely online, so it renders itself very well to virtual mobility. And we're also trying to market the program through other networks we're involved in, such as the European University of Disease, the CEU project, of which the University of Malta is a member, and why not, perhaps even through INHWE. There could be scope for expanding the program through that as well. We constantly gain constructive feedback as an opportunity for further development. We insist that our external examiners do not just fulfill their formal duties, but they give us critical feedback, both on an individual level and also collectively. In fact, we organize several team development activities to improve as a team, and feedback from the students themselves, both during and after the modules, but also we give them the opportunity to give feedback to the external examiner with no lecturers present, for the simple reason because we feel that helps us to improve the program. And perhaps an important point is the fact that as health professionals, most of us tend to be very much aware of what we do and what goes on in our health entities, whereas participants, clinicians might not be so aware about what goes on in other health entities and perhaps what other health professionals really do. And I think this course has been an eye-opener in that manner as well. Through the deep discussions that took place as part of this program, students became much more aware about what goes on in other settings and what other health professionals do. And this has been very inspirational to several of our health practitioners. And some threats to the program: online fatigue nowadays, and even more so with this pandemic. Most of the things we do are done online, so perhaps learning online becomes a daunting task, since most other things are done online nowadays. Initially, one of our challenges was skepticism about the benefits of online education, and also insecurity about delivering things, learning through an online learning platform. We try to address this both through training, but also through mentoring and sharing of experiences with less experienced colleagues. Competition from similar programs, both local ones and international ones, could be a threat. And also the fact that the reduced number of participants could render some of our elective modules unsustainable if only a very small number of participants choose them. And the numbers might dwindle even because, as time goes by, the number of participants who need to do our program, so to speak, is decreasing because, first of all, several professions are now degree only, and secondly, several master's programs are accrediting prior learning, which means that students can join a master's program even without having a bachelor's degree. And finally, a couple of other threats: evolving student population. So at the very beginning of the program, most of the students were mainly very mature health professionals. Nowadays, most of our students are newly qualified staff. This is fine, of course. It means the program has evolved, but we did notice that this impacted on the depth and quality of online discussions, and even on the enthusiasm and the joys, the literal joys of learning. So perhaps younger students just want to get their degree, whereas more mature students really want to enjoy learning. Group work, this ties in very well with the previous workshop that we had, that different members of the same group may have different levels of commitment to the task that is being done as a group. And lurking, which is well documented in the literature, and there's a session about this later on today, I believe, as part of the program. That is another threat to our program. And despite the open channels of communication, unfortunately, several students do not reach out adequately and do not perhaps feel a sense of connection or community, and their journey ends up being a lonely one. So to conclude, these are some lessons we learned. I know I'm almost out of time, so perhaps you can read through this, but basically we learned that developing an online program requires a team effort, bringing together a team of eclectic disciplines. It's important to be constantly receptive to the backdrop, to the context in which the course is given. What works well with one cohort perhaps might not work so well with other cohorts, so the students' context and circumstances must be constantly kept in mind. But perhaps our greatest lesson was to quote the maxim from Voltaire, about which most of you, I'm sure, are familiar: perfect is the enemy of the good. Had we waited for the ideal conditions and had we waited for the perfect team to be formed, most probably this program would never have set off. So sometimes you have to take a risk. Reflective on what you did well and what can improve. In our case, determination and some pedagogical and IT skills and also vision were adequate to create a team that managed to move this program forward for over a decade now. I thank you so much for your attention. These are our contact details. We will be very happy to discuss any elements of this presentation and the course itself at a later stage in this conference. So thank you so much for listening in.
Brilliant, thank you. Well, thanks for the introduction and for accepting us to the conference. I'm joined also by Geraldine Latchem-Hastings, who is a senior lecturer at Cardiff University in the School of Healthcare Sciences, and she's going to be here with me to respond to questions later on. So we are both members of the centre, the Coma and Disorders of Consciousness Research Centre, and that's an interprofessional research centre at Cardiff University. Today's a really lovely opportunity for us to tell you about the team-based learning approach that we've taken to interprofessional, continuing professional development for healthcare professionals about caring for people specifically in a prolonged disorder of consciousness. Okay. So for those of you who aren't aware, prolonged disorder of consciousness is an umbrella term for 3 particular conditions: coma, the vegetative state, and the minimally conscious state. And caring for these people is, is really complicated due to just their completely profound impairments. And their care is not only medically complex, but it's complicated by social, ethical, and legal contexts. And our own research within the Coma and Disorder of Consciousness Research Centre has highlighted some really urgent training needs for healthcare professionals working with this particular patient group. And that's primarily things around communication with families and particularly best interest decision making around continuing or withdrawing life-sustaining treatments. So people in a prolonged disorder of consciousness in PDoC require care of an extensive multidisciplinary team, and that's a team who really learns to work very closely together because their traditional roles are really heavily disrupted due to the profound impairments of this population. And as a research centre, we've delivered hundreds of lectures or presentations and courses on site to individual professionals or professional groups. But we've come to recognise that if we want to really change practice in this area, we need to engage full multidisciplinary practicing teams in the same place at the same time. And we've recognised that for practitioners in this area, they do often work in tight teams, but they're always considered the expert and drawn on really extensively. And so in a way, often work in isolation. And they really need to connect and come together to learn with other professionals working in this area. So we know that, flipped classroom can work really well, and we had developed a course for undergraduate healthcare professionals at Cardiff University that around PDoC care, and that was really drawing some excellent learning outcomes. So in a bid to address the learning and access needs for multidisciplinary teams in practice, we then developed a team-based learning approach to help us drive change in clinical practice, and developed a multimedia online learning course for these qualified professionals. So what do we mean by team-based learning, and what are we interested in? Well, I think given this morning's plenary, we wanted to kind of be upfront about what we're meaning by team-based learning, and maybe how closely we are or not aligning with the model that was highlighted in the session and then the pre-reading. So for us, team-based learning is structured flipped classroom, combining self-study ahead of real-time gatherings, but it's also specifically for us about creating an environment and making possible learning in and by real-life multidisciplinary clinical teams. And to make that possible for us, the classroom had to be entirely virtual, and that was a decision that we'd made long before COVID was really forcing virtual classrooms. I think where we're deviating is in our readiness assurance process. So I think we nailed the pre-class study and have elements of individual readiness testing built into the pre-study, but we don't really have the formal type of team readiness assurance process, although we're drawing on principles of debating and exploring practice issues through group discussion very extensively through the course. Also, in terms of deviation, unlike the exacting model that was presented earlier, our application activities can always be carried out in multiple discrete teams that stayed together through the course due to the shifting nature of attendance during the COVID time. And what we're really interested in is how flipped learning elements and a total virtual learning environment has enabled team-based learning within clinical practice settings, and has connected and created multidisciplinary teams across hospitals, regions and countries. So as you can tell, this is a bit more of a team-based learning inspired approach and some partial application. So our course then, well, it's research-led. It's focused on core research from the CDoC Centre, and to a point it was co-produced with healthcare professionals and family members. It certainly hasn't been made overnight, and the course we have today is the product of gradual development over the last 5 years. The current course is made up of 8 online interactive self-study modules, which take between 1 and 3 hours to complete, and you can see from the slide the broad areas the modules cover. The online materials we have include short lectures, presentations, quizzes, reflective practice activities, interspersed with visual arts, some poetry, a really moving puppetry performance, shadow puppetry performance, and we're combining our clinical practice experience, sociology, bioethics, and law and media expertise within the course. And of particular note, our course includes lots of clips from interviews that we've conducted with leading experts in the field, families and frontline healthcare professionals who have really candidly shared their experiences and talk about particular areas of clinical practice. And then the self-study content of the course is then accompanied by 5 real-time seminars and is paired with evening Twitter chats. So using a flipped classroom approach, individual modules are released one at a time for self-study ahead of pre-scheduled seminars. And the self-study content was intended to get students ready by equipping them with both the functional knowledge they need before the in-classroom activities, but also to unsettle those who are self-identifying as experts, to really draw out and to, encourage them to recognise gaps in their own knowledge at the beginning. Learners then come online for real-time seminars, and we've held those using a platform called Blackboard Collaborate, and the online seminars are then lasting between an hour and a half at a time. For us, the seminars had 2 sort of key purposes. One, to provide this protected time in a working day for staff to come together to share and learn. And secondly, to act as a space for practice-based experiences to be shared cross-centre, cross-region, cross-country, and to draw out problem solving around approaches to the very challenging aspects of PDoC care. So our in-classroom application activities focused on team-presented current clinical cases and practical challenges, or where required, some tutor predefined scenarios. And while the teams weren't required to sort of arrive at a singular decision around what were often quite complex ethical situations, learners were always asked to express why and how they thought what they did, what they felt was influencing their opinions, values, or suggestions they were putting forward. And then the seminars were followed by evening chats, which mirrored the seminar topics but were very condensed versions and opened up, and we were literally tweeting 3 to 4 questions in an hour's discussion for drawing sharing of practice and experience. So who were our learners? Well, we've had 222 people register for our courses in 2019 and 2020, and learners came from multiple healthcare professions, like you can see from the slide there, and they came from over 65 different healthcare organisations across the Republic of Ireland, Northern Ireland, Wales, England, Scotland and the Channel Islands, and many joined as full or near full multidisciplinary teams from specialist centres or from across hospital departments. So one example, one hospital trust released learners from intensive care, acute care wards and their connected rehabilitation centre to attend the course. Now in 2020, COVID did disrupt us, so that did mean that while some learners did complete the course in April as planned, others did have to withdraw due to being redeployed or their own sickness. We did run sessions later in the year in September to try and kind of mop up and support those who were really desperate to finish the course to do so. And overall, we were just super impressed with how much engagement we did achieve in what has been, the most challenging year for everybody in healthcare. So before, during and after the course, we gathered a range of information and feedback about learner behaviour and engagement, and collected continuous feedback using a range of methods, including interviews with learners, discussion in seminars, tweet chat transcripts, that sort of thing. All components of the course, so self-study, seminars, tweet chats, did provide a really useful learning opportunity for learners in isolation. Everything was really well attended, everything was everyone was really engaged with everything, and there was lots of really positive and interesting debate. Collectively, we feel that the course provided learners with the flexibility they needed to engage due to the multiple kind of access points we are offering. In terms of the self-study materials, engagement with that and feedback about it was just hugely positive. Learners praised our comprehensive nature of course materials. One experienced speech and language therapist, for example, said, "Thank you for collaborating and creating this. It's 15 years of my experience taught in a few weeks." And learners really noted and appreciated that engagement that they had with one another. So someone said, "Heartfelt thanks, it's really made me feel like we're not alone." And another said, "It was great to hear and benefit from other groups of professionals from different centres and hear from their experiences." And lots of comments really focused on the importance of the videos with professionals and family members that I told you about earlier. Those clips really seemed to invite reflection, promoted people to see things from different perspectives, and was considered really valuable in the dialogue. One of our favourite comments in feedback about the course came kind of from that sort of place. Someone said, "The course examined so much, the good, the bad, the ugly, the difficult, and it felt like a safe place to explore." And we were really very, very happy with that comment. But in terms of learning outcomes, new learning was definitely achieved across all modules, and even those that had been designed maybe to equip less experienced learners were also really appreciated by experienced clinicians who were able to reflect gaps in their knowledge, which is really what we wanted. So specific learning around PDoC demographics, the social construction of the condition and its media representation, so things that were slightly different in comparison to traditional clinical courses, were really valued. We have a particular focus on family experience from our research, and that drew out all sorts of improvements for communication and care. And evidently we didn't want learners to learn for learning's sake, but we wanted them to make practice changes. And to our delight, many learners reflected their plans for change within their own practice, or their will to engage their organisations to drive change, particularly around best interest decision-making processes, which again was a particular aim for us for the course. Critically, learners were coming away with a much better understanding of best interest decision-making. And one learner kind of summarised this when she said, "We all need to challenge what we thought we believed was right and reassess our actions to make sure we're doing the right thing by our patients and what they would have wanted." So what do we think was going on and what was achieved? Well, through engagement with the course, we really felt that teams identified the core challenges within their real life teams and sought solutions to areas of challenge from other teams represented during the course. For some of them, they'd never sat down as a team, as a multidisciplinary team, and openly acknowledged the issues in their practice to one another. And this model seemed to create a space for acknowledging the struggles for individuals and the teams, and then opened up a space to then actively seek solutions. So how are we going to make this change? What are we going to do about it? For us as tutors, hearing the contemporary examples of what they're facing and challenging really helps us then further develop the course each time to meet any emergent practice learning needs. And so we've got this sort of live and emergent curriculum development going on. Critically, the course provided team for those who maybe didn't have one and working maybe in the community in isolation, or were in a big multidisciplinary team but they were missing maybe one or two professions for some reason. It united practitioners across the Republic of Ireland and the UK, as well as teams dispersed across large hospital trusts or regions in a way that just isn't possible through non-digital means. And in doing so, the model provided a cost-effective way of teams to learn together and minimise the disruption of taking clinicians away from direct patient care. So, and as Joseph said, that's normally a really kind of key barrier for team learning and engagement. Now, there are lots of challenges to delivering this type of course, but we felt and find that they are surmountable, and the benefits for us certainly outweigh the challenges. I'm really grateful for Joseph earlier for highlighting the challenges, and essentially what he said we certainly experienced as well. Okay, I think that's pretty much what we want to say. There's some contact details for us there. If you want to know more about the PDoC Centre, you can see our website there. You have our emails, and you can follow us on Twitter at PDoC UK. Thank you very much.
Thank you. Thank you so much for a very stimulating presentation. I'm reminding our attendees that we will answer all questions at the end of the session. Thank you so much.
Familiar with what an escape room is? An escape room is a live action team-based game in which players begin in a locked room and have to escape. Players discover clues and solve puzzles by engaging with their surroundings in order to escape, and all tasks must be completed within a time limit. So this approach emphasizes teamwork, delegation, communication, critical thinking, lateral thinking, and attention to detail, which arguably are all really crucial skills for healthcare workers. And escape rooms are a growing trend, particularly in North America, Europe, and Eastern Asia, with an estimated 50,000 escape rooms worldwide. Why use an escape room within medical education? Well, we've seen a growth from kind of the use of personal computers and the vast use of the internet, and this has paved way for diversifying and incorporating games into education, particularly outside of a primary education setting. And this is known as gamification, which is often defined as the use of game design elements in a non-game setting. And looking at the literature, we can see benefits such as motivating, inspiring, and engaging learners. Learners feel focused and accomplished after the learning event. It's been seen to improve knowledge acquisition, content mastery, and motivation. And importantly for our new teaching staff, it increases perceived learning compared with control groups. And this is important in helping build confidence in our staff so they feel happy using the equipment and take the focus away from that, and so that they can focus on the simulation that they're involved with. There's been limited use of escape rooms within healthcare education, and I've divided these from the literature into three main groups. The first is team building. So this is when you take a group of healthcare professionals to a commercial escape room and they complete it, and this is used to promote team building. It's been found to be engaging, fun, non-threatening in a non-clinical, low-stakes environment that rewarded teamwork and effective leadership. The notable skills that have been seen to be gained from that would be task delegation, collective brainstorming, data sharing, and organic leadership. The second main focus is within research. So an interesting paper I saw was where they created a digital escape room as an adjunct to a traditional lecture teaching dermatology. And they used the information from how candidates navigated this escape room. And finally, escape rooms have been used to promote learning. So an example of this was during residency orientation. They created an escape room in a simulation room, which had multiple patient safety hazards. And the team had to scan QR codes when they saw these hazards, and then they had to enter these risks into the hospital reporting system. So it was both helping candidates identify any hazards and then get them used to using the hospital reporting system. For us, what were we aiming to teach? So within NHS Lanarkshire in Scotland, we have a team of educators consisting of nurses, doctors, and technicians. And we deliver undergraduate and postgraduate immersive simulation courses in our simulation suite across a variety of specialties. And this for our faculty involves the use of several pieces of equipment. So the first would be the SimMan, and we have to be able to use the various functions of this, responsibly change vital signs and speak as the patient to the participants. The second is using the cameras and a computer program, so we use SMOTs. So you have to be able to responsibly move the cameras as well as bookmark, record and playback video for the use of debrief. Thirdly, we want to ensure that our teaching staff are confident in using mannequin blood arms that candidates use for venipuncture and ABGs. And finally, and arguably most importantly, we want to promote non-technical and particularly communication skills, as you can never conduct a sim alone, you always are working in teams. So common challenges within this environment include being confident using this equipment quickly and effectively whilst real-time simulation is unfolding, and being able to troubleshoot any arising equipment issues and minimizing the disruption that this can cause. So prior to our teaching session, our escape room, training for new teaching staff was experiential based and didn't have any kind of formal structure. And whilst this was useful, it did lead to discrepancies in learning. So we wanted to improve on this by incorporating a gamification approach to design a teaching program that was more practical and memorable than perhaps a traditional didactic approach such as a lecture. In terms of the design, so we had 10 participants consisting of nurses, doctors and simulation technicians. And this course was delivered during their induction at the commencement of the academic year. So this was all new staff. We divided them into teams of 2, and participants had 45 minutes to complete 24 tasks that involved the use of different simulation equipment. And afterwards, participants were given allocated time at the end to consolidate and make sure that they were confident, working alongside the technician without any kind of time pressure. So they had a kind of free session at the end to look at the equipment. We designed this escape room in order to emphasize communication. And so we had one candidate situated inside the simulation room, and the other was separated via the one-way mirror in the control room, and therefore requiring different instructions to be sent or communicated through the one-way mirror. So particularly at the start of the escape room, they don't have any means to communicate, so they have to use the equipment and build on tasks. So we added an additional challenge there. And tasks were completed sequentially, meaning that one piece of equipment had to be used in order to progress. And once you use that piece of equipment, then another clue would emerge. We collected both quantitative and qualitative data in the form of a pre- and post-course questionnaire, and quantitative data was in the form of a 5-point Likert scale. So looking at the pre-course questionnaire, in terms of our participants, so 80% of our new staff had some prior experience of using this equipment. However, when we looked at how confident they felt in using it, with one being a low level of confidence, 40% reported a 1 out of 5 pre-course confidence level. Half of our new staff had a 2 out of 5, and 10% had 3 out of 5. Looking at after they've done the escape room, in terms of whether they felt that it was challenging but not distressing, 100% of participants felt that it was an appropriate level of difficulty. And in terms of whether they felt it was a useful learning experience, 100% of candidates felt that it was. In terms of the qualitative data, it was across the board felt to be a positive training experience. Our new staff felt that they had increased levels of confidence using new equipment, had improved memorability, and they felt that particularly working with a diverse team, it enhanced their learning. One of the questions was how to improve the course, and we had several comments relating to logistics, but overall no kind of large-scale improvements were suggested. In terms of future directions, so this course has now been introduced to the formal induction curriculum for new incoming teaching staff within NHS Lanarkshire, and we're also looking to expand this design to other trusts as well. Thank you very much for your time and bearing with.